Good morning, everybody. I'm Armin Brott with Men's Health Network, and I want to wish you all a happy Men's Health Month and welcome you to today's Congressional Briefing on men's mental health and COVID-19. The briefing is being co-sponsored by the Men's Health Network, and hold on a second, I just lost my notes. PCORI, which is the Patient-Centered Outcomes Research Institute, the Men's Health Caucus of the American Public Health Association, the National Alliance of Healthcare Purchaser Coalitions, and the Milwaukee Fatherhood Initiative. Just a couple of very quick bookkeeping details. Today's topic is really critically important, and in order to give our panelists the greatest amount of time to make their presentations, we're going to be saving questions for the end, and I'm also going to be giving very, very small bios. There's a website on the screen right now that will give you information and a link to their more detailed bios. You're going to also find links on that site to the resources that our panelists will be discussing during their presentations. If you've got any questions, please do send them over. Use the chat function on Zoom, and we'll get to as many of them as we possibly can after all the panelists have presented. And if you're a member of the media and you have questions, please contact Men's Health Network directly so we can set up an interview with you. Without further ado, let me introduce Representative Donald M. Payne, Jr. from New Jersey's 10th Congressional District, who's going to get us going. Representative Payne, in addition to his extensive work on a variety of congressional committees and subcommittees, has a lifelong strong interest in health issues and is the chair of the bipartisan Congressional Men's Health Caucus. Congressman Payne, thanks very much for joining us, and get us going.
Thank you very much. And good morning to everyone. It's a real honor to be here for your Men's Health and COVID-19 Congressional Briefing. I want to thank the Men's Health Network and the Men's Health Caucus for the invitation to speak with you here today. Given that June is Men's Health Month, it is perfect time to hold this event. In fact, I introduced a resolution commemorating June as Men's Health Month in Congress this year. It is something that I've done every year for the past 6 years. In addition, I founded the Congressional Men's Health Caucus to bring more awareness to men's health issues. And men's health awareness is more important now than ever before. Both Black and white men are more likely to die. Both Black and white men are more likely to die than Black and white women. White women outlive white men by 5 years on average. Black women outlive Black men by 7 years. Part of that reason has to do with the stigmas that exist for men's health. Too many men still believe they can handle minor health issues on their own. But without medical assistance, minor issues can turn into major, life-threatening ones at different times as well. Most women outlive men because they visit doctors and specialists for routine health checkups and screenings regularly. It is a situation that is even worse when it comes to mental health. Men are far less likely to seek help and treatment for mental health conditions than women. That is why men are 4 times more likely to commit suicide than women. And suicide is the 7th leading cause of death for men. Overall, 6 million men are diagnosed with depression annually. That number does not include the millions more who refuse to seek mental health care. Instead, more men are likely to label mental health concerns as physical health concerns. They say they are overworked. They say it's the weather. They blame it on other people. Anything to avoid the perceived stigma of depression and mental health issues. The reasons have to do with old ideas of what it means to be a man. But today, gender roles that men feel obligated to obey are killing them. We know the pandemic has increased mental health issues for men and all Americans. Studies show that alcohol and marijuana use among men increased significantly during COVID-19. These substances are popular forms of self-medication. In general, more than 4 in 10 Americans reported symptoms of anxiety or depression last year. The number is 4 times greater than 2019. Clearly, mental health is a growing concern for all Americans, but it is a potentially fatal problem for men. That is why discussions like this one here today are so very important. They help remove the stigmas around mental health care. They help men understand that mental health is just as important as physical health. And they allow men the freedom to discuss their issues with anxiety and depression with others. This is so critical a step to recovery, whether they talk about it with family, friends, or medical professionals. The only way we can improve men's mental health is to allow men to address it without fear or shame. And given the increased issues with mental health during COVID-19, this is the perfect time to do so. So thank you again for inviting me to speak to you about mental health, and let me know how I can help your efforts in Congress in the future. Thank you so much.
Wow, Congressman, that was very powerful and very comprehensive. I'm so glad that you mentioned that the issues about stigma and about the disproportionate suicide rate and the substance abuse issues. We're going to get into all those in more detail, but that was a really wonderful overview. Thank you so much. I want to introduce our first panelist, who's Dr. Sal Giorgianni, who is Men's Health Network Senior Science Advisor and the Chairman Emeritus of the APHA's Men's Health Caucus. He's also the primary author of a series of really valuable monographs that I hope you'll all have a chance to read that were based on the PCORI-sponsored expert panels that Men's Health Network convened to discuss men's mental health, and the many ways that COVID has affected it. Dr. Giorgianni is going to be discussing that work and the intersection between COVID and gender. Dr. Giorgianni, you're up. You're on mute, though. Oh.
There we go. I keep forgetting to do that, but don't tell my wife if I know where the unmute button is. She's been looking for it for a while. Thank you very much, Congressman, for that wonderful introduction to the topic area. And we appreciate you and the other members of the Men's Health Caucus in Congress and other members who pay attention to the issues of health in boys and men. It's a very important one. Men's Health Network, next slide, please. Men's Health Network, yes, my disclaimer, I have no financial conflicts of interest that won't prevent me from giving an unbiased, rounded presentation. So just want to put that out there. Next slide. As Armin mentioned, PCORI, the Patient-Centered Outcomes Research Institute, and Men's Health Network recognize the importance of taking a deep dive on many of the issues associated with mental health in boys and men. Much of that work was prompted by a 2018 data collected by CDC that showed that there was an amazingly high rise in suicides of boys and men, which traditionally is run about almost 4 times that of suicides in women. And that's sort of an underlying thesis to what we were doing, that mental health is a huge problem in men, assuming that you agree that suicide is a mental health issue. There's an awful lot of mental health out there. We were fortunate enough to receive some financial support from PCORI, which led to the development of this first piece, which you see off on the left-hand side of the screen, which was a survey look at all of the issues involving and creating and exacerbating mental health and suicide in boys and men. It was a panel of 25 experts from around the country who offered their opinions and perspectives. It not only outlined some of the problems that are faced, but also very importantly, laid out many of the things that these panel experts felt needed to be addressed in order to correct the problems of mental health in boys and men. It also offered some very important suggestions and recommendations for outcomes-oriented research that needs to help provide information to help guide and inform future decisions on how we progress with this. Uh, Men's Health Network was very fortunate in getting additional funding for other programs. We took some of the recommendations, particularly the recommendation about the importance of community involvement in addressing, identifying, and help manage mental health in boys and men early on. And then COVID hit. So our world changed dramatically. Once again, PCORI was very gracious in providing funding for Men's Health Network as COVID-related issues were important to PCORI and Men's Health Network. So we did a deep dive in a series of 3 subsequent monographs, which were all posted on the Men's Health Network website at www.menshealthnetwork.org. And these 3 series in COVID looked at the clinical implications of the issues that are surrounding COVID on the mental health in boys and men. The second one looked at some of the important economic implications and how they have affected mental health in boys and men. And then the third looked at minority men and vulnerable populations and how COVID has adversely and disproportionately affected many of these men and boys, everything from the issues surrounding Black Americans, health and welfare, Hispanics, Latinos, Native Americans, LGBTQI, and also some of the forgotten vulnerable populations, including foster children, victims of sexual trafficking, and other individuals with intellectual disabilities. So it's a very comprehensive look. Each of these had panels of experts that we believe will offer a lot of insight. So what I'm going to present to you in the next couple of minutes is a very quick summary of some of the important findings, and I'm going to leave it to my fellow panelists to expound on those. So the next slide, we'll take a quick look at the impact of COVID-19, impact on chronic diseases, which is really the first in the series of 3. As we all can appreciate, healthcare was blunted just as every other aspect of life during the very important mitigation techniques that we were all asked to engage in. Unfortunately, what this is leading to is lost year, actually a year and a half now, of chronic care management for boys and men and women, just all Americans, in order to manage their chronic care disease. So this has expanded not just from diseases such as diabetes, hypertension, and other cardiovascular disease, mental health issues, but also in cancer treatments, where a lot of treatment was pushed back because of the closures of health facilities, as well as the reluctance of patients going back. It's also set up a mindset, which is one of the challenges that we're going to have to face as we come out of this acute phase of COVID in the next several months and several years, getting these people, particularly the men, as the congressman pointed out, who are much more reluctant to go seek health care in the very beginning, getting them back into the groove of looking at their health care and capturing men who really don't normally provide. So one of the areas that was very important in bringing men to care during this COVID period was telehealth. Men's Health Network has long supported the issue of telehealth. It helps address many of the issues, including stigma, that are associated with guys getting treatment, particularly for mental health conditions. So we're hoping that telehealth programs will continue, and then pay parity for services under telehealth is an important parameter the panelists brought out as well. Impact on long haulers disease. There was a very interesting paper just published recently about long haulers disease in pediatrics. So my generalized comments here about the challenges that long haulers face is applicable to pediatric patients now, as well as adults, and that's just a new perspective. And you'll see here outlined in white are some of the symptomatology associated with this COVID long haulers, which is, when you think of the number of Americans who have been affected by COVID, ones diagnosed and ones have not been diagnosed, that's a huge number when you think about 30%, according to CDC and NIH estimates, of these individuals could be affected by long haulers. Clinicians don't know how to address this. So and they're not fully aware of long haulers. They might hear it, but they don't really understand how to address it or how to diagnose it, or even how to identify at-risk individuals, because there may be some reluctance to even talk about that they had COVID. So one of the challenges we believe is going to be in the future is looking at making clinicians aware of the long haulers disease, encouraging them to screen individuals, and giving them some guidance on what to do. You can see this isn't just a physical problem, but also it has many mental health implications in a demographic, guys who already have many mental health problems. One thing I'd like to point out as an enhancement to the concept of the mental health issues in guys is that 80 some odd % of the individual men who commit suicide have never been diagnosed with a mental health condition. So a lot of this is buried in there, and primary care providers in particular need better assistance, guidance, education, and encouragement, including reimbursement encouragement, to screen for mental health problems in boys and men. It's something that they really don't do enough of now. Vaccination pushback. We're going to be pushing for more vaccinations. I am of the opinion that booster shots for COVID-19 vaccinations will be increasingly important over the next couple of years. We know that we've already had an awful lot of hesitancy, particularly in Black communities and Native American communities. So I think that that is an issue that has very broad implications, and that was delved into by our, our panel in great depth in our third monograph on minority and vulnerable populations. But also we're going to get a very strong pushback against more vaccinations. And that's not just in COVID, but we also believe at Men's Health Network, that's going to spill out into other very important vaccines. The vaccine rate, just like the management of all chronic care conditions with COVID, has been pushed downwards. And we do believe that that vaccination issue is extremely important to prevent other conditions that we have now at bay from rearing their ugly head, superimposing themselves, including flu, on COVID-19. So we think that clinicians are going to need support for how to address this issue. The average clinician and pharmacist who give vaccinations has never had to really deal with a hostile public in getting flu vaccines or measles, mumps vaccines for their kids, which is also way down. Just routine pediatric vaccinations is also down. So they're going to need some support to help to address that issue. On the next slide, that's it. We're good. Okay, but I think that should give you a brief overview of some of the important information. The series that PCORI was gracious enough to fund and Men's Health Network worked very, very hard to put out there encompasses about 200 some odd pages of in-depth information, readings, research recommendations, as well as public policy and clinical practice recommendations. And I urge anyone who's interested in advancing the health of boys and men, particularly in the mental health domain, to peruse these documents and utilize them as background. I think we're doing questions later, Armin, is that right?
Yes, sir. Thank you,
Okay,
Dr. Giorgianni. Exactly on time.
Oh my goodness.
We'll bank your time for later. Dr. Giorgianni, thank you so much for that. And I, again, as Dr. Giorgianni mentioned, all of us urge you to take a look at those things. They're at menshealthnetwork.org, and they're really well worth the read. They're filled with fantastic information and a lot of things that many people have not really heard of. There's a ton of research in there and interviews with the panelists who are experts in their field. So please do check those out. Our next panelist is Adam Bloom-Paicopolos, who's a member of PCORI's Public Policy and Government Relations team, and he's going to tell us more about PCORI itself and the valuable research, which is really terrific. I'm not saying that just because Men's Health Network has been the recipient of some of that research funding, but because they're funding a lot of other research out there to support both behavioral health issues and COVID. Adam, you're up.
Great. Thank you so much, Armin. I appreciate it. And thank you to Men's Health Network, Men's Health Caucus, and Congressman Payne for having me at this briefing. It's an honor. And PCORI is really excited to be part of this important conversation. Next slide, please. So I'd like to tell you all a little bit about PCORI and who we are. We are an independent nonprofit organization authorized by Congress in 2010 and we were reauthorized in 2019. And we fund comparative clinical effectiveness research and patient-centered outcomes research that seeks to answer the real-world questions about which treatment and what types of therapies work best for who and under what circumstances. Next slide. So our mission is really at the heart of our work and everything we do. We really try and fund research that helps people make better informed healthcare decisions and strive to improve healthcare delivery and outcomes through our results. We produce and promote this evidence through dissemination and implementation funding and engagement awards to really get the community input and engage patients at every point of our research process. And we really try and have this guided by patients, clinicians, and providers and caregivers as well to really make this research answer questions that matter. And so I think when we're talking about mental health and men's health, this is really an area where we can fit in nicely. Next slide, please. So I want to give you all a brief overview of our mental health and behavioral health portfolio, which is one of our larger portfolios at PCORI. As you can see, we funded over $500 million, close to $600 million to fund over 140 studies. And the largest area that we're looking at here is treatment. So various therapies, medications, and comparing them to see which one works better for who. And then in terms of topics, depression and substance abuse are really the two main ones that we've focused on. And we also have a fairly large opioids portfolio in general that seeks to answer some of the questions relating to substance use disorder and pain medications. Next slide, please. So I wanted to highlight two studies that I think really connect nicely to this topic and relate to our telemental health portfolio. The first of which is one of our studies that actually does have results, and it's comparing how to treat serious mental illness through two interventions. The first of which is a smartphone app that, they access information that helps manage their symptoms, and they actually have a support specialist that calls them and gets patients to talk about their symptoms, any problems they have with the app, and really engage them in this app. The other program, called the WRAP program, is more of a group clinic session. So this is more of a traditional 2-hour group session. People go into an office. It's usually handled by folks with lived experience of mental illness. And they talk about their challenges and they put together plans to help them get better. And so the results of this is that participants assigned to the smartphone program are actually more likely than those in the clinic-based program to start treatment at a rate of 90%, versus 58%. And those in the app program actually remained engaged in the program for 8 weeks of care, 56% versus 40%. And it's important to note that folks in both groups improved significantly and did not differ in clinical outcomes. And so the increased engagement by the telehealth program here suggests that the smartphone-based treatment plan may help increase access to care for patients with serious mental illness. And this is particularly relevant now as we begin to navigate the post-COVID landscape and how best to offer behavioral health care, especially for those who may be reluctant to seek in-person care, like many men tend to be. So another program that I'd like to highlight, another study, is looking at cognitive behavioral therapy for major depression in rural West Virginia. So this study does not have results yet, but it is one of our more promising studies. It is looking at guided versus unguided remote CBT. And it's comparing it against usual care as well, which in West Virginia tends to just be antidepressant medication. And so patients in the first group receive usual care plus the guided remote CBT. And this has coaches with them that remind them to take medications, monitor side effects, determine if their medications are working. And the second group just has access to the remote CBT without a coach that's checking in on them. The primary outcome here is looking at remission from depression and also medication adherence. So I think this has a lot of potential to answer a lot of questions that are coming out of COVID and remote telehealth mental health care. Next slide, please. So in addition to our usual activities, PCORI has responded to COVID-19 through several of our existing funding mechanisms. We started the HERO Registry, which provides infrastructure for investigating questions that matter to frontline healthcare workers. And we approved $30 million in funding for a special COVID-19 targeted funding announcement. And we also provided funding to 116 research, engagement, and dissemination implementation projects that we called COVID enhancements to expand or adjust their work plan in the face of the pandemic. Of this funding, about 4 awards touch on mental health in some capacity in terms of the targeted funding announcement. And we had 4 special cycle engagement awards that also touched on behavioral health, spanning from mental health in high-risk COVID populations to mental illness and substance abuse treatment during COVID. Next slide, please. So one of the projects I'd like to highlight here that received the COVID enhancement funding is out of Vermont. This is looking at integrating behavioral health and primary care. And, as Congressman Payne had mentioned, a lot of times, there's a stigma around seeking behavioral health care, around seeking care. And a lot of times, the first time men come into contact with the behavioral health system is through their primary care provider. And so this is really looking at how we can best integrate this model, whether it's just a co-location where it's a behavioral health provider in the same area, or if there's a more integrated approach in terms of training and getting these providers to work together and make a plan. The COVID enhancement this received, the research team wants to learn whether an integrated behavioral health system lessens the impact of COVID-19 on patients. And their hope is that these results will be able to inform the type of healthcare delivery that best meets the needs of the general population and behavioral health as well. Next slide. So one of our 9 COVID targeted funding awards that I mentioned is looking at mental health in minority and underserved communities. So we know that worry, stress, and then generally mental health conditions are traditionally underserved and undertreated in minority communities. And the pandemic has only exacerbated these feelings and exposed a lot of inequities in our system. So this study is comparing 2 types of mindfulness-based stress reduction interventions that reduce worry before it leads to more serious mental health challenges or physical effects as well. So again, a nice tie-in with COVID especially is one is a smartphone app and the other is a video teleconference doing this intervention with a behavioral health provider. And it's looking specifically at patients in predominantly low-income minority areas. The hope here is really that we know MBSR is an evidence-based program that has a lot of flexibility to it, and that the results here can, provide actionable findings that can be adopted by the healthcare community, both during the pandemic and after, and provide a lot of much needed information on how to address the mental health concerns of this population, again, not just now in the pandemic, but after, and what the long-term effects of a lot of the worry and stress around COVID has on this population. Next slide, please. So this is just some future activities we have somewhat related to mental health. We're going to be doing a briefing on opioids and substance abuse disorder in the future, highlighting some more of our work. And then we are going through a national priorities refresh right now, where we would love all of your input, welcome your perspectives both on this topic and as it relates to others. I think this is really an area that there is a lot of possibility to move on. Next slide. Thank you again to Men's Health Network, the Men's Health Caucus. I really appreciate your time, and we'll be doing questions at the end, right?
Yes, Adam, thank you so much for that. That was just great to learn more about PCORI and the work that you're doing. And thank you on a personal level for supporting so much of what Men's Health Network has been able to do recently on this particular topic and other topics. Our next panelist is Michael Thompson, who's the president and CEO of the National Alliance of Healthcare Purchaser Coalitions. He's going to tell us about an innovative new approach to helping patients with mental health and or substance use disorders. And I hope you'll touch on this, an interesting distinction between substance use disorders and substance abuse, which most people talk about. But you're using the term substance use. Anyway, Michael, thanks for being here with us, and please tell us what's going on.
Yeah, so I thank you so much for the Men's Health Network and the Congressman's great work in this area, and frankly, PCORI, who's been a great partner with the National Alliance. We have a partnership with a number of key organizations in the employer community, the HR Policy Association, as well as the mental health community, like the American Psychiatric Association, the Meadows Mental Health Policy Institute, and others, the JED Foundation. And it's really looking at systemic issues in the mental health system that will reinforce a number of the points that have been made previously. Go to the next slide. So, prevalence obviously very high for mental health. I think this audience knows that. And I think the part, though, that is a little less appreciated is how ineffective we are at supporting people with mental health. 60% of cases go undetected, undiagnosed, untreated. And there's minimal screening for early detection, a 10-year lag between disease onset and diagnosis. And it's because the system wasn't designed to support mental health effectively. If you go to the next slide, what has been the outcome? In every other area, we're doing much better. Cancer's down, stroke is down, heart disease is down, suicide is up. And it's because the system, it isn't because society is suddenly becoming less attuned to the issue of mental health. In fact, all the cultural elements around mental health are getting better. People are much more accepting. Stigma is actually being reduced. There's a lot of momentum building on the societal cultural elements. The system is getting worse, and that's part of the problem. Next slide. So this group came together about a year and a half ago to collaborate on what we described as the path forward for mental health and substance use. And the idea was to look at the evidence-based issues that are getting in the way of people getting diagnosed early and treated effectively for mental health and substance use disorder. Next slide. So what are those 4 pillars that we're focusing on? The first is network access. This seems like it would be a given, particularly through employers. We provide insurance, there's mental health parity. Doesn't everybody have equal access to mental health services as they do for everything else? The answer is an absolute no. Try to get an appointment through your network, and it doesn't work. It doesn't work effectively. It could be a 6 to 8 week. There are stories of people calling people in the network listed in the book and not getting a phone call returned from 8, 10 different providers. They're kind of the phantom networks. And this is a key issue because much of the care is being delivered out of network. And if you want to talk about equity, if the care is delivered out of network, you're paying out of pocket for the deductible, the co-insurance, and frankly, very few Americans can afford to pay for this care out of network. The second issue is collaborative care, which is integrating primary care integrating mental health and behavioral health into primary care. And there's an evidence-based model, the collaborative care model, that has 70 random controlled trials that delivers outcomes and is reimbursed under Medicare and under most medical plans, but it's not common practice in the United States. And there's a change effort that has to be mobilized and frankly needs funding at the federal level to get mobilized so that we do diagnose early in primary care and that we practice evidence-based care in primary care for mental health, where most people seek services for their mental health. Measurement-based care is the idea of measuring early to early diagnose, but also measuring as care is delivered so that treatment patterns are improved during the course of care. And the evidence shows that if you use disciplined measurement-based care in mental health, you improve outcomes 20 to 60%. And obviously, telebehavioral health is one of the bright spots that has emerged during COVID-19. It's exploded, but the policy issues to sustain the gains that we've made with telebehavioral health could not be more important or more critical than they are right now. Many of the gains will get reversed if the policies revert to being more restrictive on permitting telebehavioral health going forward. Next slide. But the basic point of this is it does deal with these issues around stigma and the fact that people can't get access, promotes 100% screening, trains primary care to effectively treat. It boosts access to in-network specialists, and it promotes improved access in rural communities and inner cities through telebehavioral health. Next slide. And the net gain on that, you know, will we spend more on behavioral health? Absolutely. And we need to. But will that have a return? We represent the purchaser, the plan sponsor community. If we early diagnose, it will be less expensive later on. If we treat it, it has a mitigating impact on other conditions for men and everyone else. And so we need to be responsive to this behavioral health, these behavioral health priorities to move this agenda forward. And I think that might be it. Is there anything left? Next slide. So I'm going to turn it back.
Whoa. Wasn't expecting that. You still have 4 minutes left. We'll have some, hopefully some great questions. Wanted to introduce our next panelist then. We'll just move right on to Darryl Davidson, who's the Community Engagement Director for the City of Milwaukee and also the Director of the Milwaukee Fatherhood Initiative. And Darryl was one of the first people in the country actually to notice and more importantly to raise awareness of the disproportionate impact that COVID was having on men in general and men of color in particular, which is something we've obviously, Congressman Payne mentioned at the very beginning, and has come up a number of times that men have been disproportionately affected by COVID for a variety of reasons, and we'll get to some of those in the Q&A. But Darryl, tell us about what you discovered and everything else.
Thank you, Armin. And I do want to acknowledge Congressman Payne, as well as our guest panelists, PCORI, and our Men's Health Network for making this happen today. I also want to put together some of the things that were stated earlier and make sure that people know some of the highlights that we talked about, including outcome-oriented research and recommendations that Sal talked about. Adam gave some insight on how precise we can be with some of the things that PCORI was doing with the research. You'll find that information at the Men's Health Network website, menshealthnetwork.org. Take a look at the Men's Health Network library. If you go to that link, you will see the information from PCORI. And as Sal mentioned, there are 5 monographs that give information regarding the research and the study that influenced the presentation that he did. And then Michael gave some great information about what's going on with the measurement based efforts to improve the outcomes, and also spoke to addressing it from a policy perspective related to mental health. And from the city of Milwaukee and Milwaukee County, we are the ones who were first in the country to identify racism as a public health crisis in May of 2019. In the process of this period, we also identified specific areas for Milwaukee County's community health improvement plan. And some of those things included identifying 3 specific issues that we were going to work with. One is positive mental health, which completely is aligned with what we're talking about here, as well as the inclusive and fair society and economic security. Milwaukee's African-American community is heavily affected by many income inequalities. It's a population of about 600,000 people. Approximately 39% is African-American represented in the city limits. Health access, residential discrimination are historical issues. We saw what happened with the essential workers. Many of them were people of color, and those essential workers were on the front lines of what was taking place related to COVID and infection. And also, this is the population that primarily depended on public transportation. Now, what we also saw was that much of the data that we were taking in was not matching the rest of the cities in the country. Part of the belief is that many of the campaigns that were introduced prior to COVID becoming the emergency that we saw it become, there was an emphasis on an aging population or an older population, and ultimately much of the focus went in that direction. But what we saw was that of the initial cases in Milwaukee, Wisconsin, 50% of those initial deaths were African-American males. And if you take a look at the rates of cases, 829 was the rate for African-Americans, where it was for COVID infection, COVID cases, 169 for white. So we saw a huge disparity, not that it wasn't different than what we would have seen historically with heart disease and with other chronic illnesses. It's just that we recognized early that we had to take a different approach in the intervention activity. We also saw that there was a comorbidity activity related to people becoming ill with COVID, as well as it becoming more serious if they had diabetes or heart disease or any other chronic illness. So what we wanted to do was make sure to motivate men to get tested, as well as emphasize that the population was going to have resources even if we were going to be quarantined. Many behavioral factors, such as people being on the job, there was more exposure in certain job environments, less masking was taking place with men. Men were very likely to practice less social distancing. Historically, again, men were going to the doctor less for routine checkups. That played a role in what we saw as far as our rates of COVID. And so the other elements that were included in there, the mental health factors. Behavioral health was influenced by mental health because everything was driven by the economy. So if the businesses were shutting down and there was a rise in unemployment, there was income loss, there was financial insecurity, that was leading to higher reports of trauma and mental distress. And so early on, Milwaukee County Behavioral Health, as the example on the right side of the screen shows, we began having conferences and sessions, virtual meetings, telehealth activity that was related to mental health and reducing the stigma. So starting off with stress and sadness, and even talking about anger and a variety of emotions, that was being addressed. So if people were expressing those things in phone calls or with their friends, we encourage people to call so that they would find out more from the supporting activities through the Milwaukee County Behavioral Health, as well as the partners with the City of Milwaukee and the City of Milwaukee Health Department and the Milwaukee Fatherhood Initiative. We know that emotions are normal, and so regularly every month there were sessions that were introducing how people could cope during this period of time. Let's go to the next slide, please. There was a huge benefit to having coalitions and partnerships in place. They already were established in a major way when we created our community health plan, and that was about 5 years ago, where we found individuals and organizations who identified if there was a public health crisis that took place, where we could refer people and how they would exist in that particular space as the experts. So multidisciplinary teams, we had organizations that received calls. And what we also saw during that period within, as you'll notice on this chart, during the dates of the COVID pandemic, particular times of the day, there were higher rates of calls during that time. So much of it was asking for law enforcement resources, perhaps related to family violence situations. There was dedicated to increasing the capacity for someone who may have been infected and didn't have resources for residents, and also for any type of information that might have affected the families that had school-aged children. We received a lot of calls related to that because when people were at home, safe at home, guidelines directed them on how to stay in their residence, but it didn't direct them on how to interact with their family members. So we had help from social media as well as health and other partners that assisted them with how they were going to conquer some of those regular routine problems that we would have experienced from either isolation or from being around individuals who they may love and care for, but they typically were not around them typically. Let's go to the next slide. So our lessons in Milwaukee, early on, we knew that some of the first things we had to do was start the quarantine as quickly as possible, even if that meant that there was some discomfort. We had conferences, including the National Democratic Convention, that were coming to the city. They did not come to Milwaukee, Wisconsin during that period. The governor mandated the closing of bars and restaurants right before St. Patrick's Day was a huge economic loss to the city also, aside from the conferences and the festivals that no longer could be conducted. We developed culturally specific messages around testing, as well as recruiting and identifying sites to distribute the personal protective equipment and masks. And we also made a concerted effort to counter misinterpretation. So there was evidence that people were saying that certain populations did not get COVID, and we had to create public service announcements and bus tags that identified that that was not true. We also promoted many different responses that were taking place in the community that were at the most local level. And that's one of the recommendations that comes out of here. We really want public health to invest in the infrastructure for more local coordination. We were able to identify how many cases were in each aldermanic district, and we were able to create a strategic response around that. We are using best practices to evaluate the effects of chronic stress and stereotyping among racial discrimination. And also, as mentioned before, telehealth services with mental health components needs to be strengthened, and the policy recommendations around that need to be addressed. Next slide. So I don't have anything to add with this. I know that we're going to go to questions. So if you have more questions related to the specific ways that we address the situation, let us know.
Darryl, thank you so much. It's really a pleasure to hear about things that are happening. And I know PCORI deals with this, the patient outcomes research. There's so much talk about how systems are failing and things aren't happening. And it's easy to complain about it, but it's wonderful to see that what you're doing and what Michael is doing and other people are doing is really trying to address these issues. I know that Congressman Payne has got some time constraints, and I want to make sure that we are able to get him before he has to leave. I just had a question that really didn't get addressed here, but it's something that's in the background of so many discussions about men's health, which is the Office of Men's Health. I know that that's something that Congressman has been involved with in the past, that there isn't currently any Office of Men's Health in the federal government or otherwise, and there are quite a few offices of women's health. I'm wondering if there's any progress on the campaign to create an Office of Men's Health.
Well, hello?
Yes.
Okay. I think it's an issue that we continue to push in the federal government. There hasn't been anything lately that we've heard, but with the new administration, we continue to seek to accomplish that. But to this point, right now, I would say that it's still in question, but in review.
Okay. Anybody else want to add anything to that? Okay. There want to talk about something that Michael made an interesting connection about trying to integrate mental health into primary care, which is something that the Men's Health Network has been talking about for quite a while, and it's something that clearly needs to be done to really bridge the gap between mental health and physical health, because the people tend to think of those as being completely separate issues. And I'd like to have Michael, if you can start with this, and maybe we can open it up to the other panelists as well, talk about the connection between mental health and physical health, because again, we have a tendency to think of them as separate issues, but there is so much impact. I mean, the clearest connection between mental health and physical health obviously is suicide. That's the most obvious manifestation of it, but there's also the stress that happens and the stress related injuries that happen. Can you address that and why it's so important to integrate those two together?
Yeah, we talk about it in the context of total person health, that you don't do well just by looking solely at the issue in front of you. You have to think holistically around the individual, and that can manifest itself in terms of multiple chronic conditions. It can manifest itself with mental health condition or substance use condition in conjunction with another condition, or even the social needs and how that kind of ties into that broader issue around the individual. You know, primary care that looks holistically at the individual will outperform, because oftentimes mental health issues or social issues get in the way of people taking care of the rest of them as well. And we know that people with mental health conditions are far more costly, not just on mental health, but on every other condition. And so ignoring the issue does not make it go away, and nor does it make the other issues go away or get treated better. People are less compliant if they are depressed or anxious. People are less able to get control of their lives more effectively. And so we have found that organizations that look holistically and integrate behavioral health with primary care into primary care actually outperform in the long term in helping that individual manage their health effectively. And again, I think the evidence is very strong in that regard. It's the execution that is lagging.
Darryl, is that something that you folks in Milwaukee are dealing with as well, trying to get people to understand the close connection between mental health and physical health, and why they really, that they may be treated separately, but they do connect, and they are impossible to separate, really?
That is a big priority in our city. Our mayor, Tom Barrett, is a big proponent of addressing mental health, physical health, and comes more from the standpoint that untreated mental health is just like a fire in the home. You're going to, if it's fire starts in the kitchen, on the oven, if you address it early, then it's not a problem. But ultimately, if you don't address it, it's going to burn down the kitchen. It's going to burn down the first floor. It's going to burn down the entire home. So mental health obviously is connected to physical health, but physical health is connected to mental health. People who don't feel well, they're not getting enough sleep. They are working, they're overworking themselves, they're experiencing pain and discomfort. That affects their mental health. So it's highly intricate, and it's connected to one another.
Excellent. One of the questions that came up, somebody sent in the Q&A, was about what's being done to address mental health issues in men and boys, and what's, in a way, what's keeping those issues from being addressed. And that's something that Men's Health Network, the very first program that we did with PCORI, was a panel that we assembled to talk about why it is that men are not being addressed. These issues are not being addressed in men and boys. And one of the things that we came up with, and I'd like Sal to talk about this, Dr. Giorgianni, to talk about this in more detail, about just the screening tools, for example, that are available. They're really designed to flag symptoms of mental health issues in women more than in men. So they talk about more, they ask questions about whether you've been tearful or whether you have feelings of worthlessness, and they don't flag more male symptoms, which have to do with overwork or social isolation or substance use. So Sal, can you talk about that? What we found in the panel, and also what you wrote about in that amazing monograph.
Yeah, thank you, Armin. It is a problem. Men's Health Network has reached out to many potential funders for projects and programs specifically to the issue of mental health in boys and men. And I will tell you, just as it is in the overall issue of funding for men's health programs, it's a tough road to hoe. It's a bit of a Sisyphean task. So we continue to help talk about the importance of addressing these factors. And we are doing the best we can with the resources Men's Health Network has. Part of the dilemma, and it goes back to this issue of physical health being related to mental health. Men, generally speaking, show symptomatology and signs of mental health issues, emotional hurt, very differently than women do. Men are much more likely to express their emotional hurt by blaming people, by being hostile, by engaging in physical manifestations, and also somatic symptoms of just stomach problems, malaise, sleeping disorders, lack of being able to get up and do things that they normally like doing. So the panel addressed a lot of that in the clinical implications monograph, as well as in the economic monograph. So one of the dilemmas we find is that most of the common screening tools used in the clinical setting and some of the screening tools used in the community settings for HR personnel, for even first responders, military, they don't gear towards the way guys express their emotional hurt. They're geared towards the rhetoric, the language that women do. So it's not that guys don't necessarily express their emotional hurt, but they express it very differently than women do. So one of the things Men's Health Network has been advocating for, and we're getting a little bit of interest in it now, is to help try and develop a male-centric, and there are a couple of small examples out there. One of our panelists did an excellent job of doing a male health emotional screener for first responders. But we've been advocating for doing that kind of male-centric screening tools for quite a while, fielding them and evaluating them. We're also concerned a little bit about the fact that there are no guidelines for screening for mental health in boys and men. So particularly in the primary care arena, which is driven by guidelines and national recommendations, not one of the mental health or primary or medical specialties have specific guidelines for that in guys. We see them in women. It's usually contextually appropriate, but there is no guidance to encourage that being done. The third issue our panel pointed out is parity in reimbursement for mental health problems in guys when you do screening. One of our panelists, who's a primary care physician out in Arizona, who's a member of the American Academy of Family Physicians focus group on this area, talked about how she picked up on a potential suicidal guy. She and her staff had to spend several hours in not only identifying the problem, but getting him to a safe place and getting him help. It took several hours, but their reimbursement rates were very, very small. She didn't exactly say how much, but my guess is it was probably the same as any sort of general physical reimbursement rate. So there has to be consideration of parity for mental health screening, mental health triage in primary care for there to be movement, significant movement in that arena.
Yeah. Excellent. I wanted to ask this to Darryl. It has a couple questions that come in that have to do with men coming in for services. Is that going to be a possibility as the city of Milwaukee opens up? And we'll take the city of Milwaukee as a bit of a representative, hopefully, for the rest of the country. And also, if not, are telehealth services available to address men's mental health issues for those who choose to, and hopefully more will, try to get services?
So our group education classes through the Milwaukee Fatherhood Initiative have already started. We have appropriate social distancing, and there are smaller groups in large facilities. And those are fairly regular to the point where we have daytime classes, evening classes, and we're about to start up on our weekend schedule. As far as it goes with the behavioral health services through Milwaukee County, most of what's been taking place recently has been remote telehealth, as well as any type of activity with remote activity. It's been fairly successful because they've been operating, getting the clients from referrals, and they didn't slow down as far as on their telephone calls. They received them from National Alliance of Mental Illness, as well as through a service that we have locally, our 211 support services. We are going to be opening up in Milwaukee in July, going into August. Some of the activity, again, will be small group work. As far as it goes with individual services, I would expect that much of that is going to take place in the fall under the programs that I'm taking a look at. And we've also been creative because some of our work, we are moving into parks and into parking lots if we're able to do it in the daytime, if the weather permits. So we're trying to be as creative as possible.
We're just about out of time, and for those who'd like to stay, we can hang on for another 15 minutes if our panelists are able to do that, because there are quite a few questions. But one that I think is incredibly important in the context of this entire discussion has to do with whether the mental health providers are culturally reflective of the men they serve. And that's something that we addressed quite extensively in our cultural paper on COVID and the impact on men, because there is absolutely a shortage of providers of color and people who are able to speak directly to with the cultural impact of COVID on men, and to be, people who go and see any kind of a healthcare provider want to have somebody who looks like them or who has some sort of cultural similarity, or they can understand where they're coming from. And that is something that needs to be addressed on the recruitment issue, and also on by finding community important people in the community who can help with these things. Just wondered, we haven't really heard that much from Adam. If you'd talk a little bit about, have you seen any on PCORI's side of requests for funding or studies that are already being funded that deal specifically with the cultural issues?
Yeah, I think that's a great question and a really important point. I think, unfortunately, there's not too much on the behavioral health end, but more broadly in our portfolio, we've seen a lot of cultural tailoring projects be very successful in a variety of communities. And I think that's definitely something moving forward, knowing behavioral health is becoming more of a crisis and something we need to look at, that absolutely is an area moving towards. And I think, I'd like to bring up the project that I highlighted just at the end there, looking at mental health in minority communities during COVID, is that with these apps that they're looking at, because they're so flexible and because we can really change them up so much, they're going to be looking at ways to culturally tailor these to their audiences to be impactful, because worry for one community might be completely different for another community, right? And how to reduce stress and the different stigmas attached are absolutely going to be different. And I think as we're looking more at these telehealth delivery platforms and then apps as well that are more easily accessible and more easily able to change, there definitely is area to tailor these to make it so it's relevant to the folks we're trying to reach.
Dr. Giorgianni, could you add a little bit to that as well? Unmute.
Yes, there we go. It's very important not only to tailor these programs to different communities, cultural needs, rural versus urban versus, New York versus Dallas, so regional, but also to the guys. I think one of the observations many of the panelists and Men's Health Network has made over the past is that there's not enough emphasis on doing something specifically for the guys. Part of the dilemma we find is that there are a lot of great programs out there developed in general or developed for a specific demographic, but then they are not, they try to translate into programs for guys, and it just doesn't resonate. They don't pull it. So one of the things that we urge folks to think about is that if you're going to try and reach out and do programming, research, community initiatives, communication aids for community workers to help them understand how guys express emotional hurt, how to get guys to come to care, you have to do them from scratch as a male-focused demographic. And men are not just a monolithic group. There's a huge range, of course. We all know this intuitively, but that's not necessarily reflected in the work. So we also believe that it has to be not only designed by sex, but also by gender preference, and also by demographic. It's a huge amount of work, but if it's going to make an impact and engage guys, young guys, old guys, middle-aged guys, it has to be targeted as one would do in a marketing campaign. It has to be segment targeted. We don't see an awful lot of that. Also, the issue of telehealth, extremely important, but telehealth doesn't address all of the ills. We still need to, and many guys don't feel comfortable with it. Certainly in rural communities, they don't have exceptionally good telecommunication portals. There's a lot, dark areas where you're not going to get good signals or web-based internet connections. So that has to be addressed, and I think that is being addressed. But then there's not equipment. Some of the guys don't have it. They don't know how to use it. But you still need to have, and this is one of the areas of focus for MHN, a community connection, those trusted messengers, those interlocutors with whether it's faith-based organizations or barber shops or athletic groups or schools where those one-on-one connections, those individuals who do need that, proactively go out and look at that. We encapsulate a very important program that was done for National Guard, where they proactively identified men who might need some help in mental health, and then they called them up, and these guys were like, wow, no one ever asked me if I needed help, and I do need help. So we need to review the entire approach that we take to boys and men based on the way boys and men want to get that information and what pulls them in. Is that helpful? I hope, Armin?
Absolutely, yeah.
Yeah.
Congressman Payne, I just wanted to get you back into the discussion, and this is obviously you're coming at it from a completely different perspective, but from what you're hearing, how is this, do you think, going to influence the kind of legislation or programs that you might be interested in supporting? You're obviously very much on board with doing something with mental health and men's mental health in particular, but are you hearing some needs perhaps that you hadn't been aware about?
Well, absolutely, and I appreciate the discussion and conversation. I really, it's really just a good opportunity for me to sit back and listen and understand the issues that that we're facing from the professionals here, from Darryl, from the doctor, from Adam. So I'm really actually doing my job, taking in the information and seeing, how we can move forward and be helpful to each other. And, from my capacity as a member of Congress, there are a few things that I think I've heard today that we can go back and look at and see how we can be helpful in the situation. I wanted to mention that I think one of the benefits out of this terrible situation that we've had over the last year is, the implementation of Zoom and WebEx and these platforms that allow us to interact pretty much seamlessly, but we all know there are technical difficulties with some of this technology, but it's opened up a whole new availability of interacting with each other, and also I think has been a benefit to moving forward telehealth. You didn't really have much of a choice in the last year. So I think normalizing the use of telehealth to the extent that it has been a benefit. And so, I just think there are just so many issues that we have to tackle. And Darryl, I want to commend you for the work you're doing there in Milwaukee. And Doctor, the information that you have as a professional is so valuable. And Adam, to be working on the nonprofit side of things shows a true commitment of your organization. And so anytime someone's working not for profit, it says a great deal about the organization and their character. So, I'm just delighted to potentially have new partners in this space. I haven't done a great deal in mental health, that space, but know how important it is. I mean, full disclosure, I don't necessarily feel very good every day that I get up mentally. And, there is just stress and strains that are put on all of us. But, as we stated, to be consistent in my message, the stigmas around it, suck it up. We heard a few of the other sayings that we use to not deal with it. And which is actually what you're doing is you're not dealing with it. Suck it up, or stiff upper lip, whatever it is. We have to come to a point where we say that we need help, and it doesn't make you any less of a human being or a man to say that you need help. So we have to understand that that's all right, and provide an environment where men feel that it is all right. So just thank you for all the information that's being disseminated today.
Well, thank you for those comments. We're just about out of time. There's one question that came in that it's a bit of a general question, and I think we addressed it somewhat. A gentleman from Brazil was asking about whether, he said there used to be some research in Brazil that was showing that men don't go to the doctor as often as women do. Is the same thing happening in the United States? And the question is absolutely yes.
Yes.
And there's no question that men are about half as likely as women. Even if you take out all the OB related visits, half as likely to visit a doctor. Most men haven't seen a doctor in the last year or two. And one of our board members who's not able to be on the call, Dr. Jean Bonhomme, who's on the faculty at Emory University, Emory Medical School, talks about this. And it starts with exactly what Congressman Payne was saying with when we're little, we're constantly told big boys don't cry. Then we join a sports team and we take one for the team, and you see all this glorification of athletes playing with injuries. And then so it's no surprise that when a guy in his 40s or 50s starts having chest pain or horrible other kinds of pain, he says, it's just indigestion, I'm not going to bother to go to the doctor. There's so much about masculinity and that's tied up in not making us go to the doctor. And so the congressman is exactly right, and it's great how it just ties right back into what you said at the very beginning. It's okay, and we need to understand that asking for help, whether for a physical health issue or a mental health issue, is not a sign of weakness. It's a sign of strength. That men, our families, our children need us to be alive and healthy, and if we don't ask for help, we're going to be doing everybody a disservice, and including and ending our lives prematurely.
Yeah,
so,
I mean, if I could make just one more
absolutely
one more comment or example, a clear example of what we're talking about. I came to Congress probably the worst way anyone could come to Congress because of the death of my father. My father, Donald Payne Sr., was the member of Congress from New Jersey 23 years prior to me arriving there. And he passed away from colorectal cancer for the simple reason is, the old stigma about not wanting anybody to examine me in that manner. He needed a colonoscopy and just wouldn't do it because of, machismo or whatever it is, and lost his life. So, that's the clearest example of what we can say and with reference to men not doing what they need to do.
On that note, I want to thank Congressman Payne and the Congressional Men's Health Caucus, Dr. Sal Giorgianni, Adam Bloom-Paicopolos, Michael Thompson, who had to leave a little early, and Darryl Davidson, also to the sponsoring organizations, Men's Health Network, PCORI, the Men's Health Caucus at APHA, the National Alliance for Healthcare Purchaser Coalitions, and the Milwaukee Fatherhood Initiative, all of whom made this briefing possible. I learned a lot, and I hope you did as well. And of course, thanks to everyone who joined today's briefing and submitted questions. On behalf of our panelists, I want to really encourage all the guys out there to pay more attention to your health. If you haven't seen a provider or had a physical exam lately, do it. Your family needs you to be healthy and alive. And we wish you a great rest of your day and your week, and a happy Men's Health Month. I think we're done.